quite widely used.
Okay, I see it's 7 o'clock. Maybe we should just start by asking both of you to introduce yourself so that the colleagues, the audience may know you, and then we'll take it from there.
Go for it, Nirav.
Profs must go first, but anyways, my name is Nirav. I'm Patel. I'm a pediatric surgeon based at Barra in Johannesburg, Soweto. And I actually met a very nice, kind man many, many years ago, and his name was Prof Brand. I met him at Helen Joseph Hospital when I was a fifth-year medical student. And he was part of my journey to become a surgeon. He's a hepatobiliary surgeon and a prof now. I'm still a regular old Joe, pediatric surgeon at Barra. I'm very happy to be here. And actually, I want to congratulate you. I don't know if Prof has been involved in the starting of this, or if it was just you to Sunny. But really, I want to congratulate you. We all want to do what's right for patients. We want to do what's right. We want to do the best that we can. And sometimes in trying to do the right thing, we sometimes don't do the right thing. And that does materially impact our patients, most of whom are extremely impoverished. So it's lekker. This is a great platform. I'm very happy to be here. Thank you for setting it up, and congratulations to you.
Thank you. Doc, just for the audience, get to know better, what is a pediatric surgeon, and then what does it take to be a pediatric surgeon?
So a pediatric surgeon is a surgeon for children. It depends where you work, what is defined as a child. But we do surgical procedures on children from the ages of 0 to 14. So pediatric surgeons can be thought of as the last true general surgeons, because we used to do almost everything. So we can do operations on the neck, in the chest, in the abdomen, urological operations, gynae operations, tumors. But as the field is developing, we're sort of becoming more specialized. So we don't do any neurosurgery, we don't do any orthopedics, and we don't do heart surgery, but we do pretty much do most of the rest, yeah? So, anything in your chest that involves the esophagus, that involves the lung, any tumors, anything related to the GIT, the gastrointestinal tract, most urology, most gynae, most soft tissue stuff, a lot of trauma. It's quite nice. It's very, very broad.
So what does it take, Doc, to be a pediatric neurosurgeon? A pediatric surgeon?
So first you have to qualify as a medical doctor, and then you do your normal 2 years of internship, 1 year of community service. And now it's a 5-year specialization. Most places you have to have some general surgical time. So you have to do your primaries and your intermediates, which takes about 12 to 18 months in general surgery. And then you'll join to become a pediatric surgeon. So that'll be another 5 years of specialization. So that's the academic requirement. The other requirements to be a pediatric surgeon is that you have to love children. You have to love surgery. You have to love working hard. And you generally have to have like a reasonably pleasant demeanor, because your patients are the children themselves and their parents. So it's no good to be grumpy like some general surgeons. It's no good to be aggressive. But it's very fulfilling. It's a kick-ass job, I must tell you. It is a fantastic job. You have the best patients. It's very hard work, but it's extremely rewarding. It's really lovely. If anyone wants to become a pediatric surgeon, just WhatsApp me and we'll take you to Barra. You can see what it's all about, and hopefully we can welcome you in a few years.
Thank you, Doc. Prof?
Yeah, I'm the opposite. I don't have to be nice. I don't carry lollipops in my pocket. Hepatopancreatic biliary surgeon is what I do. It's a liver, gallbladder, biliary tree, pancreas surgeon. I think we've done this before, Jonathan, but anyway. How to get there? Medical degree, as said. A year or two of internship, can't remember, it was quite a while ago. It was 2 years, and then following that, my course was that I went overseas for 3 years. I did my MRCS, which is a basic surgical degree in the UK. Came back, I did my general surgical training. I then did 2 years for a PhD. So I was fortunate enough to get a fellowship from overseas to do that. I then joined surgical gastroenterology, where and then following that, I did an 18-month stint overseas in Singapore, doing quite a highly specialized HPV subspecialty time there. And then since I've been back, I spent a bit of time at Barra, then jumped ship and went across to University of Pretoria, where I'm the head of HPV surgery. Very heavily involved with students from fourth year all the way through, very heavily involved with surgical training, and also quite involved with surgical exams and subspecialist exams.
Thank you so much. I think the audience can see that you are really in good hands. So let's just go straight to the topic today. So the aim, Prof, before you join, is that by the end of this session, I want everyone in the audience to be very crystal clear. When do we say a child or an adult has constipation? Without any confusion. If a patient comes and presents right now, the audience should be very crystal clear to say, oh, this is constipation. And then my wish is to also quickly highlight the different types. How do I differentiate from this type to this type? Simply, and then when to refer, because these are clinical associates. They are not gonna do most the most of the management. But I'm glad and I appreciate that you did share the management, because now the significance of that is that sometimes when the patient are being down referred and you don't know what was done on the patient, it becomes a little bit more difficult to continue manage that patient. Whereas if you know what was done that side, then it becomes more easier for you to continue from there. So without wasting any time, Prof or Doc, you can start by we can start by one of you. I'm not sure who would like to start, so that we start with the Prof. Now in your definition, Prof, you use Rome criteria 4, right?
Okay. I was actually giving our new guest an opportunity to go first.
Oh.
Unless he doesn't want to go first.
Oh, no, sure. I'm very happy to. Okay, so look, constipation in children, I'm sure everyone's listened to the voice notes. Constipation in children is very common, yeah? That's the most important thing. There are Rome criteria to define constipation, but remember that the Rome criteria to define constipation is related to functional constipation. So before we even think about that, we just need to think about what is constipation, who are the children that get it, what are the danger signs that would suggest that the patient should go for more specialized treatment, and if those are not there, how do you define functional constipation? What's the pathophysiology and what's the approach to management, right? Mm. So, broadly you can say that constipation is a person that struggles to pass stool for a period of a month, right? So what do we mean by struggling to pass stool? We mean that it's painful, we mean that you get bloating, we mean that you get abnormal posturing, we mean that the stools are very hard, we mean that the bowel movements are very infrequent. So that's generally what it is, right? You don't need to have a specific definition for it. Amongst children, the most important thing about constipation is that you get two groups, okay? So the first group and the most common group is the functional constipation. So we'll talk about that just now. But the second group, and this is the one that shouldn't be treated at sort of clinical associate level, and this is where a lot of mistakes happen. That's the patient that has organic disease. That's the patient who has the constipation is a manifestation or is a symptom of something that's bigger that's going on. And you can think of those causes as two big causes. You can have medical causes and surgical causes. So the medical causes are very broad. It can be related to medication that you're taking. It can be related to problems in your heart, problems in your thyroid, electrolyte abnormalities, cerebral palsy, developmental delay. It can be related to a whole bunch of other things. The second group of patients with organic constipation are patients with surgical problems, and this is also a very important group that often gets misdiagnosed. So these are patients that have like a surgical problem that's causing the constipation. So the most common ones are patients with anorectal malformation, so where the anus is not normally placed or absent, patients with Hirschsprung's disease, patients with an anal fissure, patients with a small left colon, those kinds of things. So the most important thing when you first see a patient with constipation is, number one, does this patient have constipation? Are you struggling to pass with stools? Yes, you are. Is it prolonged period of time? Yes. Okay, you have constipation. Second thing you need to ask is this constipation a symptom or a manifestation of a bigger problem, or is this just constipation? So when you're trying to answer that question, there's some red flags that you need to look for. So before you even touch the patient, you need to take a good history. When did the constipation start? Did you pass meconium stool within the first 24 hours of life? Are you reliant on enemas? Is there blood in your stool? Do you have failure to thrive? Do you have any other obvious medical or surgical disorder that can be the cause of this problem? If the answer to that is yes, then you know that you're not dealing with functional constipation. When you do your examination, you want to go from head to toe, because the causes of constipation, like medical and surgical causes of constipation, can be in the brain, they can be in the spine, they can be in the abdomen, they can be in the perineum, they can be everywhere. So you must examine the patient thoroughly. And then there's the important things that you must look for. Does the patient look generally well, or does the patient look chronically ill? Does the patient have an obvious neurological disorder? Does the patient have an obvious spinal disorder? Is the patient walking properly? When you examine the abdomen, is the abdomen distended? Is there an obvious mass? Remember that an abdominal examination is not complete until you look at the perineum and do a per-rectal examination. Is the anus normal? Can you put your finger in and do a per-rectal examination? Is there a mass? Is it the normal caliber? When you put your finger into the anus, is there a normal contraction? Does the patient have normal sensation? All of those kinds of things. If the answer to any of those things is no, then you know that patient has organic constipation, and that patient should not be treated as a run-of-the-mill functional constipation. That patient must then be transferred somewhere where someone can have a more detailed examination and look for and do more detailed investigations. So now, if the patient is fine and you don't see any of those danger signs or symptoms, then you must ask yourself, does this patient have functional constipation? And there is a definition. I mean, we use the diagnostic criteria of the Rome criteria, so the Rome 4. In my note, I said it was Rome 3. I'm so sorry, it's Rome 4. And you must have two or more of the following, right? So you must have straining, abnormally large stools, difficulty in evacuating with pain, possible incontinence, which we know is pseudo-incontinence, those kinds of things. So if you have two or more for more than 1 month, then you're diagnosed as having functional constipation. So what's the approach to functional constipation? So functional constipation is like a chronic problem that gets reinforced by behavioral change. So essentially what happens is that for whatever reason, you get a stool bolus in your colon and your rectum that's very difficult to pass. Because it's very difficult to pass, it causes pain. Because you're in pain, you engage in stool withholding behavior. So you don't want to pass the stool. But because you don't want to pass the stool, what ends up happening is that you get stool impaction in your rectum. That stool becomes drier and drier and drier, and it becomes bigger and bigger and bigger, which means that it's even more difficult to pass, which then reinforces the cycle of stool withholding behavior. Does it make sense?
Yes.
So that's the basic problem. And in order to address the problem, you need to do three things. The first thing is that you have to get rid of this fecal mass. You have to get rid of it. So you have to do what we call disimpaction. So that's number one. Number two, you have to soften the stools and you have to maintain the patient so that they don't get back into that perpetual cycle of having hard stools resulting in stool withholding behavior. And then number 3, you have to get behavioral change in addition to the pharmacological treatment, in addition to the tablets and the medication that you give them, so that they don't relapse, so that this problem doesn't recur. And that's basically what it is in a nutshell. I mean, it's not more complicated than that. The problem, though, is that it's a very common problem, a very, very common problem. And if you don't treat it appropriately, if you don't engage with the patient's family, explain what's going on, explain what you're doing to address the problem, explain to them that it actually, even though it's a relatively simple problem to fix, will take a long time to resolve, what ends up happening is that the patients get frustrated, they go doctor shopping, or they go to different medical practitioners, they don't get any resolution of symptoms, and we sometimes or often miss the patients with actual organic disease. So that's what it is in a nutshell.
Thank you. So now, Doc, before I let Prof to come in, now, based on the definition, if there is a difficulty of passing stools for more than a month, then that's why we are saying this patient has constipation. Is that correct? Now, in a case where, because usually the mothers are very observant, maybe if in the first week the mother is presenting and saying, "Hey, my baby is having a difficulty in passing stool," what do you do there? Do you send back the patient, or what is the approach there?
No, so this is very important. So your assessment of the patient is as much about who is the patient as what is wrong with the patient. So we often get patients referred to us as pediatric surgeons, a 1-week-old baby that is breastfed but passed stool at birth and is now having difficulty passing stools or is passing stools infrequently. So the most important thing is to start with your basics. What was the birth weight? Are you breastfeeding or formula feeding? Did the baby pass stool within the first 24 hours of life? Yes or no? Is there any other obvious abnormalities? The anus normal? Is the spine normal? Does the patient look like he's healthy or not? Is the constipation or the supposed failure to pass stool causing a problem in the child? So is his tummy distended? Is he still eating well? Is he vomiting or not? And that's what you really need to try and assess. If the patient is well, if the patient is growing well, if he's got no feed refusal, if nothing else is wrong, then just leave the patient alone, because not every patient has to pass 10 stools a day. You know, I mean, it's like an old adage. A breastfed baby can pass 1 stool in 1 day and start passing 1 stool in 5 days, because there's other things that affect intestinal transit time. As long as the baby is well and there's no danger signs, there's nothing to do. You don't need to intervene. But the most important thing is to make sure that you don't miss any obvious abnormalities, number 1. And number 2, while you're reassuring the parents, you must also counsel them on possible danger signs. You know, if the baby is not passing stool, but you think that the baby is fine and you want the parent to be discharged, that's okay. But tell them if the baby starts to vomit, if the tummy becomes very big, if he starts to get diarrhea or fever, if he looks irritable, if he doesn't want to eat, if he's vomiting, don't stay at home. Come back straight away, because it's possible that we missed some kind of pathology.
Okay, so in a nutshell, if a patient is coming for a week or 2 and clinically you don't find anything, you just need to reassure the mother.
Yeah, you can reassure the mother, and you must exclude obvious things. I mean, you must exclude the fact that he doesn't have a fissure, those kinds of things. You know, you must make sure that you look for obvious pathology, and then you must investigate further. Like, you must think about what can be the cause of the constipation. How old is the child? If it's a baby, then you go through certain things. If it's an older child and you don't find organic pathology, then you ask them, have you recently changed school? Is there a disturbance in the home? Have you changed your diet? Those kinds of things, yeah? And even if the patient says no to all of that and you're happy that the patient is fine, you can still advise them on how to manage that. You know, you can reassure them, you can warn them of the danger signs, you can advise them to increase the fluid intake. water or juices, not milk protein. You can advise them on appropriate toileting behavior, those kinds of things. So it's not the case that every case of constipation needs to see a specialist, number one. And it's not the case that every case of constipation needs to be immediately treated. I mean, you really need to explore what may be causing the problem, with the understanding that the underlying cause of the problem can be quite a broad variety of things.
All right. Thank you so much, Doc. Prof, coming to you. Now, in your definition, you defined, excuse me, you defined constipation as having less than 3 stools per week for a month. Is that correct? So
that is correct.
So it means if a patient is saying, I'm having a difficulty in passing stools, and maybe a week I pass like once or twice, and this has been happening for a month, then that's why I'm saying this is constipation. Now, in a case as just like in pediatrics, in a case where an adult, although adults are a little bit more resistant, maybe they'll come 2 weeks later saying, no, this problem has been persisting for 2 weeks. In that case, what is the approach, Doc? Prof?
So I think there's a lot of overlap here between adults and pediatrics. For it to be labeled chronic constipation, it needs to be more than a month. So if a patient comes to you and they say, the last week or so their bowel movements have changed, and now they're going once every couple of days, where normally their usual pattern was to go once a day, that's not necessarily chronic constipation. That's usually what we would call acute constipation, and that's typically, in most cases, due to something that's changed very acutely in their lives. So maybe they've had a significant travel history. Maybe they've had a significant amount of stress at work or at home. Maybe they've had a radical change in their diet. Maybe they've started new medication. Maybe they, for example, antihypertensive calcium channel blockers are notorious, especially in the beginning when patients start taking them, causing constipation. So it's usually that kind of thing. And I would suggest that in that time period, one goes through that very basic history and then just reassures them and says, listen, if this continues for another 2 weeks or another 4 weeks, come back and see me. And then we just need to take a lot more detailed history and a lot more detailed clinical examination to determine whether or not this is going to be a primary. Nirav was talking about organic. In adults, we tend to talk about secondary, so either primary constipation or secondary constipation, where secondary constipation is due to an underlying disorder. And then one starts investigating them. But if they just come and say the last week or so has been a change in bowel habit, just a brief overview of the history, and then, as I say, advice to return to you if it continues for a longer period.
Okay, so same thing with pediatrics. In adults, if a patient is coming, so I heard you talking about chronic and acute. Let me get the terminology out of the way. So it means if it's less than a month, we are dealing with acute constipation, and then more than a month, then we are dealing with chronic constipation. So in an acute constipation, as you're saying, maybe a week or two, all you need to do is just to reassure them that, no, man, listen, maybe you try and identify the cause and say, look, you just started a new medication, you just moved, or you were traveling, so this is normal to happen, so there's no medication I'm going to give to you.
Yeah, and then also what we didn't mention is a basic abdominal examination, because what you don't want is that the patient has developed a bowel obstruction. Usually with bowel obstruction, they'll also have abdominal pain, they'll have vomiting. But some patients, if it's a very distal bowel obstruction, so maybe it's more in the rectum or the very distal colon, it takes quite a while before they present with vomiting, and they'll present initially with constipation. So one also has to examine that kind of a patient. And again, also, you have to look at the age of the patient. So a patient who's 20 years old is highly unlikely to have an underlying colorectal cancer, as opposed to a 60 or a 70-year-old patient, where if they've got new onset constipation, I would have a phenomenally low threshold to actually do an endoscopy. And that was actually one of my indications to do a colonoscopy, is new onset new onset constipation in anyone who's over 50 years of age. because of the risk of colorectal cancer.
Now, when we come to chronic constipation, which is more than a month, our main emphasis, or one thing that we should be worried about in adults, or of course considering the age, is colorectal cancer. So if a patient is coming with constipation, and this constipation has been there for it's a chronic constipation, meaning it's been there for a month, the one thing that we need to rule out is the colorectal cancer. I think we lost Prof. Are you back? Prof, are you back?
Yeah, I'm back. Sorry.
Yes.
I can just hear you. You were talking about colorectal cancer?
Yes, I was saying that one thing that we need to make sure that we rule out in chronic constipation in the more adults, meaning the people who are more older, it's colorectal cancer. We need to make sure if a patient is presenting with chronic constipation that we need to rule out colorectal cancer. Is that correct?
Yes, that is correct. And that's why we talk about the red flags. That part of your history and your clinical examination needs to be actively ruling out the red flags. And if any of them are present, the patient needs to be referred for a full colonoscopy. And just for revision, those red flags are a new onset of constipation in the patient who's more than 50 years of age. If they report rectal bleeding, either when they're stooling or in between stooling, passing stools. If they have a history of unintentional loss of weight, if they have a family history of colorectal cancer, especially in their primary family members, or if they're also at a higher risk of colorectal cancer if there's a family history of inflammatory bowel diseases, so ulcerative colitis and Crohn's disease. And we are seeing a lot more of that kind of disease in our Black African population, because it was always believed that that was a very Caucasian European type of disease, and it no longer is that. So there's no reason why a Black African cannot have inflammatory bowel disease. And then the last red flag is clinical signs, which is anemia. And if you do a full blood count, you'll see that it's a microcytic anemia. And then obviously with palpation, an abdominal mass or a rectal mass. Any of that requires an urgent colonoscopy.
Okay, now I'm gonna. Are there any questions in the audience before we proceed on when to refer this patient? Are there any? If you have a question, you can unmute yourself or you can raise your hand. Okay, or you can also type in the comment section. Now, okay, I see there's no question in the moment. So when do we refer? Let me start with you, Doc. When do we refer patients now to higher care of level? Because clinical associates are more in a primary healthcare level, so they are the first lines. So when would you recommend to say, okay, now this patient needs to be referred to a higher care? Doc?
You want me to go to Sunny? Yeah, sure. So if you pick up any danger signs, if you're worried that the patient has an underlying pathology, or if you've attempted treatment and it's failed, those are the times.
Okay, Prof?
Yeah, I mean, I would completely agree, and I think that's also relevant for adults. It's just maybe our pathology will be slightly different. So the danger signs are the red flags for us we've gone through. And if those are present, one has to definitely be worried about an underlying malignancy. If there's obstructed defecation, so in other words, the patient gives a history that they need to do specific maneuvers that help them to pass stools. So they do digital rectal evacuation, or they do pervaginal stimulation, or if they have to support their perineum. That's a patient that there's no point keeping them in the primary healthcare sector. One needs to refer them. If they have underlying organic pathology that is diagnosed at a primary healthcare level but is not responding to therapy, so maybe you have a patient you've diagnosed with hypothyroidism from a thyroid function test, you commence them on their thyroid medication, yet the hypothyroidism is not improving, or the constipation is not improving, that would be an indication to refer. Patients with underlying renal dysfunction, it tends to be uremic patients who get constipation. those are patients that need to be referred. Hypercalcemia patients, one can work them up at a primary level, but at the end of the day, the management tends to either be with the physicians or with the surgeons. So those patients I would tend to refer as well. So the majority of patients with an underlying organic secondary disorder are ones that I would refer to a higher level. Let them have their special investigations, etc. And if it's deemed appropriate, those patients will be discharged back to you, but they should be discharged back to you with fairly them. Constipation can be managed at a primary healthcare level because the vast majority of chronic constipation tends to be reasons like dietary, lifestyle, new medications. So like I said, calcium channel blockers are notorious. Your opioid and analgesics are notorious. Your antidepressive medications are notorious for causing chronic constipation. And in those situations, one can manage it by either changing the drug class. If you're not able to do that, then again, the patient needs to be referred back to the doctor who initiated those treatments. Let them change it, let them stabilize that condition, and then they will refer the patient back. I think that's where I'll stop.
All right. Okay, thank you. Are there any questions? Okay. My final question to both of you is treatment. I decided to end with treatment because I saw that it needs it's for instance with pediatrics, it's lengthy when doc was explaining that you start the patient compared to adults. So I'm not sure, doc, do you understand, or prof, you understand with the management? Now you've diagnosed, because we said if it's a secondary constipation, you said that the doc and prof, you said if it's a secondary, that patient must be referred. Is that correct? Meaning there's an underlying cause. It's not just it's a constipation because there's another pathology that is trying to show itself. So that's one, you refer it. Now, in a case where there's no
Correct.
pathology, it's a functional constipation or it's a primary constipation. Now, how do you treat it? What's the approach of treating this one?
Okay, so just think about it like this. It's 3 steps. It requires a lot of patience. It's not just based on medication. Some of it will be dietary change and some of it will be behavioral change, right? So we're dealing with functional constipation. We know that we get it because we've got a stool bolus that's very hard and difficult to pass. It causes pain. Because it causes pain, that cycle is reinforced and the bolus gets bigger and bigger and bigger. So the first thing is we want to get rid of that bolus. How do we do it? We can give medication orally or we can give a rectal washout. We generally don't like to give rectal washouts because patients don't enjoy them. They're painful, they're uncomfortable. Depending on the age of the patient, they may be very sensitive to it. So usually what we do is we give them something orally. We give them oral medication to disimpact them. We want that big bolus to come out. How do we do that? You can make the stool soft, you can make the stool loose, and you can make the colon work more. So the stool soft is something like a lubricant, like castor oil. The stool loose is like an osmotic, like Pegicol or lactulose. The cathartic, we call it the cathartic, to make the colon work a bit more, is senna. Okay. If the patient wants, you can manually evacuate them or you can do the washout. They work better than the oral medication, but most patients don't want it. So number 1 is fecal disimpaction. So we've got that. Now, number 2, you want to make sure that once the bolus is out, that you don't reform another bolus. How do you do that? You make sure that the stools are softened and loose. How do you do that? You can do that by, number 1, giving medication. So the 2 medications that we generally give are the osmotic laxatives and the stool softeners. So Pegicol and lactulose and like an oil, like a castor oil or whatever. And then the second thing that we do is change behavior, because we don't want to recreate the cycle. So we want the patient, once the stools are soft and passing naturally, to continue to try and maintain that by making sure they go to toilet at a regular time. Even if nothing comes out, they need to get used to the idea of going to the toilet and trying to pass the stool. So you give the medication, you change the behavior. And then the third thing is to change the diet. So you want to take away things that can worsen the problem, and you want to give more things that can make the problem better. So the things that worsen the problem are pap, white rice, white bread, white pasta, red meat, and milk products. Okay? The things that make it better are drinking water or juices with sorbitol, like apple juice, and increasing the amount of fiber in your diet, so increasing the amount of fruit. But the fruit to avoid is a banana, because that won't make it better. And then to replace all of the things that can make it worse with substitutes. So instead of having white bread, white rice, white pasta, you have brown bread, brown rice, and brown pasta. Instead of having red meat, you can have white meat. The only thing that we don't really have a substitute for is pap, which is something that a lot of children eat. So you've got the disimpaction, you've got the maintenance, and the maintenance, remember, is a combination of medication, of behavioral change, and of dietary change. And then the last thing is to prevent a relapse. And to prevent the relapse, you must just remember that you must counsel the parents so that they know that if the problem has been ongoing for 5 months, it's going to take another 5 months before it gets better. It's not going to get better in 1 week. So they must be patient. They mustn't become upset with their children if the child continues to have a problem. They must be supportive. And they must make sure that they adhere to the plan that you've given them. And don't go doctor shopping. Don't go to this doctor, that doctor, because there's no continuity of care there. Then you don't know whether what you're doing is making the patient better and working or not working at all.
All right, crystal clear. Thank you. Prof?
Sorry, I was just answering questions there in the chat room. So I'm not sure if everyone can read that, or should I read the question and answer before I do the treatment? I think it's a relevant question.
Yeah, you can proceed, Prof. So the question was that...
So the question is about...
You can proceed.
The question is about patients, for example, an antihypertensive patient who's been started, so a hypertensive patient who's now been started on calcium channel blockers, blood pressure is well controlled, but now they have the side effect of constipation. So I think there the assessment needs to be how significant is this constipation and does it affect the quality of life, etc., of that patient. You must also, though, make 100% sure that it is most likely the calcium channel blocker that has resulted in the constipation. Because there's no reason why a patient who's now started calcium channel blocker cannot have an underlying colorectal carcinoma, for example. You must still, it's a diagnosis of exclusion to blame it on a medication. So you still need to go through your history, you still need to exclude red flags, and then once you've gone through that and done your clinical examination, you need to be happy enough that it was the calcium channel blocker, and then you just change the drug class. So if it's the calcium channel blocker, the most common one that we would change it to is an ACE inhibitor. Once a patient's been on a calcium channel blocker, we don't tend to go back to a hydrochlorothiazide type medication. So that is the one component of the question. The other one, it's been slid up a bit. In the case of an endocrine cause such as hypothyroidism, do you take the blood test where there's no improvement on the laxative therapy? So yes, if a patient doesn't respond, and I think that was in my voice note, the majority of patients are usually primary or idiopathic constipation. You very rarely need to start them on laxatives. The vast majority of these patients, just through lifestyle and behavior changes, will actually respond. The minority of those patients, then you do need to start them on laxatives. But once you get to the point where you know that the patient's been following the lifestyle modifications that you've prescribed for them, they are doing reasonable stooling habits, etc., maybe they've started using laxatives and there's no improvement, you must look for an underlying cause because it is there. And that's why these patients, you can't just see them once and say, okay, you are an idiopathic or a primary constipation. This is what you need to do, and good luck, goodbye, see you never again kind of thing. You must follow them up. So the problem is these. So you have to give them a couple of weeks to respond. There's no point bringing a patient back after. It doesn't work that fast. You have to give it a couple of weeks. In general, we bring them back after a 4-week period, ask them have they followed your advice. If they have and they're still constipated, then you need to see what the underlying reason is, maybe start them on some laxatives. What else? Is there, sorry, I'm just seeing, you can, but it can be expensive. Yeah, okay, I agree with Nirav, what he's answered there. How do you manage the patient with overflow diarrhea, post-constipation with fecal paction still in the picture? If the patient has overflow diarrhea, it is why does the patient have overflow diarrhea? Is there a mechanical cause for that overflow diarrhea? Because overflow diarrhea is not constipation. Because if you remember, the initial diagnosis of constipation was that the patient has less than 3 bowel movements per week for at least a month. And that's where we then said you also look at the Rome 4 criteria, where you look at the type of stool. And the type of smooth stool are usually very hard, dry stools. In adults, they tend to be quite small. They are not very loose stools, because that is on the other end of the spectrum of the Bristol chart. And as we did in the previous voice notes around diarrhea, the investigation of overflow diarrhea is different. So I think I'm going to leave it at that.
Yes. Yeah. So, Prof.
So if I can then just go on to the that you asked me.
Yes.
So the management. So the general principles are, once you're happy that there are no red flags and there's no underlying organic pathology, very similar to in pediatrics, it is lifestyle changes, which include an increase in intake in dietary fiber, increase in oral fluids, tends to be clear fluids. We do advise exercise. And what you want to also must do is give good stooling habit advice. And that advice is that normally patients should defecate within 2 hours of waking up. Usually one would defecate after having a meal, and the only reason for that is that colonic motility is actually enhanced for about 30 minutes after we've eaten, and that's for various reflexes within the gastrointestinal tract. One must, though, establish a routine. Okay, patients who don't have a good routine, so maybe sometimes they go in the morning, sometimes they go in the evening, sometimes they go at lunchtime, they tend to develop constipation as well. And what's very important is that they mustn't sit on a commode for more than 15 minutes straining. What used to happen in the very old days, so when I was a child, I always remember there used to be a pile of magazines where the commode was, and then you would sit in the toilet and you'd pick up your favorite magazine and you'd read it, and then half an hour later you'd put the magazine back down and go. And that's why you won't see magazines, for example, in commodes anymore, because it just enhances bad stooling behavior. It's literally go do your business, get up and go. You don't sit on the toilet for long periods of time. If the patient has followed all of this advice and they still are constipated, you need to start thinking, is there something underlying? You can commence them on osmotic and stimulant laxatives, but you really do need to start thinking about the electrolyte abnormalities, the thyroid function, etc. We would usually start a patient on things like lactulose and fibergel. You can also use sorbitol. However, there are many more derivatives if you walk into a pharmacy. However, if those fail, so those are the basic osmotic agents, then you must look for an underlying cause before you start escalating and moving on to other types of medications. And I think that's where I'm going to stop.
Okay, so to summarize what you said, Prof, it means if a patient is coming with constipation in an adult, lifestyle modification, if it fails, and then that's where we start introducing the stool softeners like lactulose, right?
Yeah.
And then if that fails, then that's where you start looking. But I'm assuming that at that level, if the lactulose is failing, at our level, maybe that's when we should start now considering referring the patient for higher care, for further investigation.
Yeah, I would agree with that. But I mean, there's still no reason why you guys can't do the routine blood tests and then refer them on with that, because you can make such a better referral. However, if in your environment, doing those investigations is going to significantly delay the patient's referral, then I would rather refer the patient up front. So you just need to see where you are, what your resources are. No one is going to criticize you for referring a patient that has failed life.
We lost you there, Prof. But I think we got the point that no one is gonna criticize you for referring a patient. Now there's a question here. What is the role of abdominal X-ray? Do we do it or we don't do it? If we do, when do we do it? Both in pediatrics and in adults.
I think in adults, constipation itself is not an indication at all for an abdominal X-ray. However, if you are worried about maybe a bowel obstruction, so maybe the patient's got a colorectal tumor that's now obstructing, so they've got a distended abdomen, it's a little bit tender, I think that is an indication to do an abdominal X-ray. But I think what needs to be clear here, it's not the constipation that is the indication for the abdominal X-ray. It's the complication of a bowel obstruction that is the indication for an abdominal X-ray. If you're worried about a neurological disorder, so maybe you've got a younger patient, so maybe they're a teenager, maybe they're 15 years old, so they don't go to Nirav anymore, but they have a very long history of multiple years, etc., of abdominal distension, etc., and then you start worrying about megacolons and things like that, that might be an indication to do it. But I think rather in that scenario, refer the patient, because I suspect strongly that an abdominal X-ray is not going to be sufficient there. So I think my take-home message really is constipation is not an indication for an X-ray. However, if you're worried that the patient has a bowel obstruction, then it definitely is an indication.
Doc?
Yeah, it's the same thing. So we don't do the X-ray to diagnose the constipation, but often the presentation is of abdominal pain. And because the presentation is of abdominal pain, we'll usually do, if we can't find anything on clinical examination, on urine analysis, all of those things, we'll usually do an X-ray to look for the fecal loading and look if there's any stones or anything else that's going on. So it's like a basic screening test, but it's not the primary investigation for the constipation. Sometimes we do use the X-rays to monitor response to treatment, but it's not generally in the normal patient. It's in the patients that you suspect that they have a mega sigmoid, or it's in the more complicated patients with large fecalomas, those kinds of problems. It's not routine.
All right. Are there any questions? I see we are left with about admin. First of all, I would like to apologize, Prof. and you, Doc. I said the session will end at past, but I see now we've went and more about 15 minutes more. I really apologize for your time. Are there any questions on the audience? Okay. Any last word, Prof. and you, Doc?
No, I just want to congratulate you guys again. It was a great platform. It's so nice, man. Very nice. Well done.
Thank you so much, Doc. Thank you so much. And again, thank you so much for your time, and thank you so much. Thank you, guys. There's Mashudu.
Thank you very much. Can you hear me?
Yes. Go on.
Okay. So my question is, especially at the GP practice. So if a patient has been going to several doctors and then they come to you, maybe you are the third doctor, maybe the first two doctors, they give advice and counsel, and then they came to you. They say, hey, I didn't get any medication. I want medication. What do you do in that situation? Do you still give counseling, or do you just continue giving
Yeah, so that's an example of doctor shopping. So it's a patient who clearly wants to have something prescribed for them. I think here one has to take a history to see if they were actually, first of all, compliant with all the advice that they were given. But often this kind of patient are also the ones that go to the pharmacy and buy the over-the-counter stuff. And one has to hear and see what they've been using and for how long they've been using it. Because a lot of the laxatives that you use, they don't work within a couple of days. They take time before they start working. And typically it's at least a week, but usually we tell the patients that it's up to 2 weeks before they start seeing an effect and that their bowels start working more a month before that colon recovers and starts working the way that it should. So it's to have that conversation with them and to actually take them on and say, listen, this is not something that's going to be resolved overnight. It's not something that requires really prescriptions as such, because a lot of these laxatives are available over the counter. And if they are still that persistent, I would then actually just start them on something as simple as fibrogel, which has very little harm in it, and tell them they need to wait 2 to 4 weeks before they can see a response. So you give them a follow-up appointment to come see you after 4 weeks, and then see if they do come, and if they do see if they've been taking the medication, etc. And there's no reason why you can't call fibrogel and those and Senocot and those kind of agents as medications, because you are using them as if they were pharmacological agents. So that is what my opinion is. I'm not sure if it's different for pediatrics.
Same thing. I mean, same thing. You just have to be very cautious that you're not missing an underlying pathology, and then you really have to spend time to tell parents that you must manage the expectations as well. Things don't get better in a week, so you really have to try and prepare them for a relatively long journey.
Okay. We are left with 4 minutes. I see there was another person who raised their hand, but I see they lowered their hand. Anyway, thank you so much, Doc. Thank you so much, Prof. Guys, please fill in the feedback session. Prof and Doc, I'm gonna try and share the feedback session, the feedback with you. Guys, please fill in the. Thank you so much, guys. Thank you so much, Prof. Thank you so much, Doc. You are excused. Thank you, guys.
Thank you very much. Bye.
Bye. Thank you, guys. I'm kindly asking you to fill in the feedback session. Don't log off now. So that I can take your things. If you've attended, and then send it for CBD points. But please fill in the feedback session, guys. Okay, I'm gonna share the feedback on WhatsApp. I'm gonna share the link on WhatsApp, and then guys, kindly I guess you can log off then, and then I'll share the link on WhatsApp, and then please fill in the link. I'm begging you guys so that I can share it with our guest.